house. It means you have a single storage area that you over 5.9 being from pregnant women in Africa. And more than 95% of the chronic hepatitis B infection are acquired prenatally. So that still becomes our focus. But what is the progress with Uganda? In Uganda, we have had the vertical HIV transmission accounting to 18% of the new infection, but we have still seen a great improvement with over 840,000 new HIV infection among children averted over the years, and HIV testing and treatment has helped to keep the early PMTCT rate of HIV at 2.9, while the transmission at the end with the breastfeeding being still at 6.03%, and actually that is our focus area. The number of children getting HIV from their mothers has reduced from 25,000 in 2009 to 4,700 in 2024, which is a very great improvement that we have seen within our country. With PMTCT strategy, we've also seen syphilis being added and hepatitis B being integrated in 2012. Increased syphilis testing, we have seen it come from 75% to 94%, and treatment coverage at 83%. We have seen with integrating hepatitis B testing in pregnant at 63%, with a treatment estimated at 42%. We have had a cascade or a journey with triple testing. This away from 2015, when we actually had the first announcement of a pre-qualified HIV dual testing. And in 2015, the country, through the government of Uganda, supported a rollout of hepatitis B testing in the general population. In 2016, Uganda evaluated our very first HIV syphilis dual kit, which we piloted and adopted in 2016 within our country in a phased manner. In 2016 syphilis, we saw syphilis testing in pregnant women increase from 57% to 87%. And this was an impact because of the triple, the dual kits that we had introduced. More kits came on board, and in 2020, WHO pre-qualified additional kits. And in 2021, Uganda again evaluated some of those kits that were brought on board. And in 2022, we adopted another kit, and that was a standard queue added onto the previous kit that we had had. When we came, I've already noted that in 2015, Uganda had provided funding to test hepatitis B, and this was not fully reported within the pregnant and breastfeeding mothers. And so in 2020, with the partners, the PEPFAR, Global Fund, and still with the government of Uganda, we had hepatitis B testing integrated within PMTCT. And we have seen the increase from 12% in 2020 of hepatitis B testing to 56% in 2024. And even when it cannot be compared to syphilis, which came from 57% to 87% and to 99%, but you can see that there was a great improvement from 12% to 56% where we are right now. And so what is next, and what can help us to close the gap? Currently, the Uganda PMTCT algorithm is, we have an HIV syphilis dual, which we run, and once it is reactive, we report, if it's reactive for HIV, we confirm with the StatPack, and if StatPack agrees, then we enroll the patient or initiate the patient for ART. But if StatPack disagrees, and then we go through our algorithm and having the patient to come back in the next 14 days. For the syphilis, when it is reactive, we do the treatment, and when it is not reactive, we refer the patient and encourage them to do pattern testing or observe abstinence. This is to give us a snapshot of actually what is our progress. How far have we come since 2016? You can see in 2016, syphilis was at 43%, and it came to in 2019 when we adopted the first dual kit, it came to 91%. And in 2020, when hepatitis B was also brought on board, we can see in 2024, it's at 58%. And so having the dual, we can see what dual has brought on board. And so our question is, what would happen if we had a triple kit on board? There are targets that our program is looking at, that we are actually focusing on to make sure that we meet them. We are looking at the incidence being reduced less than 50 cases per 1,000 live birth. We are looking at the PMTCT rates being reduced to less than 2%, and even for breastfeeding mothers, less than 5%. We are looking at also reducing incidence to less than 50 cases per 1,000 live birth, and hepatitis B having a less than 0.1% in children under 5, and 90% reduction in new infection, and 65% reduction in mortality. And so those are the targets that we are working on. Like my previous speaker has indicated, that there is a kit that they have evaluated. Uganda also at National Health and Diagnostic Laboratory Services is evaluating the same kit, and these are preliminary results that we have also seen, the HIV, the syphilis, and hepatitis B. And we have noted that for HIV and hepatitis B kits that are already, whose results are already out, are still giving us 100% sensitivity and specificity, like how the previous presenter indicated, and the syphilis results are still underway. What would be the role of testing of this triple rapid kit within our triple elimination? Actually, that is my take home. When we have this kit, what are we going to benefit? One, the kit integrates the testing at the first ANC visit. This is a single blood drop that you get. You will save time and minimize on misdiagnosis. You can note that even when we have HIV syphilis duo, we are not at 100%. HIV is at 100%, but syphilis at 90%, 98%. And so the question would be, why are we still not hitting 100% syphilis and 100% HIV? And so if we have these all combined at the same time, we expect them to help us with integrating that. Increased screening coverage, especially for the syphilis and hepatitis B, which we have already indicated that they are lagging behind. Cost effectiveness will reduce the testing kits, staff time, and logistics. Consolidated procurement, reducing procurement costs, because instead of you procuring duo and hepatitis B, then you're just now procuring one kit. EQA production will be simplified, but also storage and distribution of these commodities to our health facilities will be made simpler, because instead of sending 2 different kits, then you're sending just one strip, and the facility will have all the 3 infections together. Because currently we have our challenge of having the disconnected distribution of these kits across our systems, or the ordering system. This will also support decentralized testing, where useful in remote and low volume facilities, especially to our community. Now they just need to carry one kit to the community and test the pregnant and breastfeeding mothers that they will find in the community, instead of having to take 2 different kits. It minimizes, it requires minimal infrastructure and reduces multiple trainings and mentorships. That means we don't need now to send out a team to do mentorship in hepatitis B or mentorship in HIV and syphilis duo. One team goes and it does training at once. Also, this will help us to fulfill the policy and programmatic impacts which are recommended by WHO in 2022 guidelines, support ANC integration, and enable harmonization and forecasting, like I've already indicated.